ours, but I have funding from NIH. I'm at the tail end of a career development award, and then we purchase study supplies from a couple of the CGM companies, Dexcom and Abbott. Okay, so here we go. So you can see the right slide. Good. Yes. All right, good. So again, I think I mentioned this already, but I'll spend the first little bit. I'm going to give some examples of different qualitative projects, and then I'd like to take a short break around the hour, and then hopefully we can make the second half interactive. So again, if you have questions about work that you're planning or actual materials that you want to share, it's totally open to that. And just to say, I think my goal for today, I know we have 2 hours, but basically, it sounds like a lot of you already are involved in some or have collaborations or interested. So that's awesome. And hopefully this will maybe spark more interest and help you think about conceptualizing, your own projects that use qualitative methods. And then I'll be doing some teaching of kind of the how to do it, but it'll be a little bit more of the like what you can do with the methods. And so maybe at some point there can be a part 2 or something that gets more into the nuts and bolts. But I also am a firm believer in with this kind of thing, you really learn by doing it. So that's why if, when we get a chance, if we can do interactive things, that's really how you learn to actually do the methods. So but I wanted to say a little bit about what drew me to qualitative research, which was that before going to graduate school, which I went to at Fairclough in the Bronx and was in Jeff Gonzalez's lab, I worked as a newspaper reporter for local weekly papers in the San Francisco Bay Area. And I really loved this work, a lot of things about it, the interviewing people, getting to immerse myself in stories and topics, and then getting to kind of put all of this information together that I had gathered into something I could communicate to an audience in writing. And I loved the work, but I also would find myself kind of asking these questions about, am I interviewing the right people? Am I interviewing enough people? Or am I choosing representative quotes? And are the things that I'm learning and the things I'm communicating, is this generalizable? So then when I decided to go back to graduate school in clinical psychology, I really found that there was this great connection between the things that I really liked about being a reporter and then getting involved in qualitative methods. And that actually qualitative methods had a lot of the questions that I was asking. And I'm sure if I had decided to go to journalism school instead, I would have gotten those questions answered from that end. But this is where I found, kind of the merging of different things that I wanted to do, because you get to listen to and give voice to people's stories, and you get to do that in a rigorous way. So today I'm going to share a few different projects that I hope are going to illustrate different ways that qualitative research can, in my view, enhance diabetes research. So that if it's something that you've already done, or if you're thinking about doing it, maybe it'll give you some ideas. Okay, so I'm going to illustrate some of this today. But when we think about qualitative methods, I think probably most commonly what we're thinking about is doing in-depth interviews or maybe focus groups with people, a certain group of people who were interested in learning from them, hearing about their experience. But then what happens? Because suddenly you have all these transcripts to analyze and to make sense of, and that can be very overwhelming, which is a totally normal feeling. And just to kind of give some connection back to when I was in grad school at Fairclough, I was very lucky to take courses and get some mentoring from, there were 2 amazing qualitative researchers there at the time, Louise Silverstein and Carl Auerbach, and they wrote a wonderful book on grounded theory, which is one of the more kind of traditional qualitative approaches. And I put together like a one-page sheet of resources and things, and the book is on it. So I can share that after this in case you want to check it out. But the metaphor that they give for starting out with your raw transcripts and going through the process of coding them is that you are adrift in a sea of data. So it really kind of is just to normalize and validate that there is that part, that phase of qualitative research where you've collected your data and suddenly you need to figure out what to do with it. But then by going through this iterative, and for them with grounded theory, it's a true bottom-up process of coding. You know, you start with the raw text, and then you start to look for repeating ideas. So things that, okay, this person said this thing, and this person said this thing, and they kind of connect together. And now I have a repeating idea. And then you keep going and adding more transcripts, and grouping these things into themes. And then finally, and if you're really doing grounded theory, you would get up to coming up with theoretical constructs, but it all will come together through this process. And so I really like this process of starting with the raw data, that feeling of being adrift in the sea of data, and then going step by step through to make sense of it. And something I say to everyone who's new to using these methods is that eventually it does all make sense, but there is this uncomfortable feeling, and especially if you are more used to the like quantitative modes of inquiry and knowing things, that it's like you're on this journey, but you don't know what the destination is going to be until you know, you have to do kind of the process to get there. And so it's fundamentally a very different way of knowing things and understanding things about our world, and about people's experience than hypothesis testing research. So we're really going in saying, we don't know. We don't know the answers, and that's why we're asking. And just thinking about this idea of bottom-up data, and that's just to contrast with like top-down, which is, you know, you kind of know going in, this is what I want to learn. I'm asking these specific questions, and then I'm going to code in this way that's already, you know, sticking with my a priori ideas and constructs. But what I like about qualitative research is that you can truly, you know, go and talk to people, and understand their experiences in a rigorous way. But in particular, it's useful for phenomena or experiences that are not well understood. So for example, you know, implementation research, if you're trying out something new and you want to know what the experience is of this new thing, I'll get into obviously with new diabetes technology. So it's good to ask the question of, you know, why do we want to talk to people in this in-depth way versus just surveying them? So I'm going to talk about 4 different projects today that I chose because I think they show a variety of different applications, for qualitative methods. The first is about the experience of understanding the context around emotional distress and depressive symptoms. The second is really focusing on user experience in new health technology. I'm going to give an example of how qualitative methods can be used to both create and refine an intervention. And then I'm going to give one example that used rapid qualitative methods, which are a little different when doing more of an implementation project, introducing a new treatment protocol into a clinic. Okay. So I wanted to start with a project that goes back to when I was in grad school in Dr. Gonzalez's lab. So just in terms of what was going on in the literature at the time, there was this question that researchers were trying to understand about whether people with type 2 diabetes, and maybe type 1 as well, were experiencing clinical depression, which is a psychiatric disorder, or diabetes distress, which is defined as an expected response to living with and managing diabetes and is not considered to be psychopathology. These are both, so depression and whether it's major depressive disorder or subclinical depressive symptoms, as well as diabetes distress, they're linked to poor outcomes. But if you knew which one someone was experiencing, you might recommend different treatment approaches. So in Jeff's lab, he was doing a few different studies on this in this area, and we were assessing among people with type 2 diabetes, we were assessing clinical depression, diabetes management in all different ways, mostly quantitative ways, and diabetes distress. And we collected self-report measures, we had blood draws, and then we were doing these structured clinical interviews, which as a trainee, this was new to me. I was learning how to be a clinical psychologist. And so as a member of the lab, I was one of the people who would get to interview participants and do these structured interviews. And one of the interviews that we gave was called the Montgomery-Åsberg Depression Rating Scale, which it's very structured, and it goes symptom by symptom. So, and you can see those are kind of examples of what this is just one of the questions, and then there's follow-up probes. So there's a question for like every different symptom of depression. And then there are these scripted follow-up questions to get at a symptom severity score. But what was interesting as I was doing some of these interviews was that, some people, when they'd be asked about these questions, like diabetes wouldn't come up at all. But for other people, they brought up diabetes. If they were asked, well, how's your mood? Have you been feeling down or depressed? They were sharing that diabetes, it's because of something that was going on with diabetes. So we were then curious to explore with, and this is not a traditional qualitative project, because this was just data we happened to be collecting from not a qualitative interview, from a very structured interview. But we wanted to know, when and how do people talk about diabetes in these interviews? So we wanted to kind of use the recordings and use kind of a bottom-up approach with thematic analysis to just ask this question of, when was diabetes coming up? Okay, so excuse me. So I'm going to share a bit about our results. We had done these interviews with 70 people, well, maybe more, but we analyzed 70 interviews from people with type 2 diabetes. And this was our sample. And I'm sorry if you are hearing screaming on my end, but my kids are getting ready to go to school. So you can see the breakdown in who the participants were. These were all people who were receiving their diabetes care, I think, through the diabetes program at Montefiore and in clinics, in primary care clinics in the Bronx. So first, another kind of non-traditional thing here, we ended up doing a little bit of quantification in our research. So what we wanted to know was not only how do they talk about diabetes, but what prompts bring it up. And I know this might be kind of small, but you can see that these are all symptoms of depression, right? Like sadness, tension, disruption in sleep, appetite. But you could see that the more somatic symptoms were where we were hearing about diabetes a lot, and less so for some of the more emotional and cognitive symptoms. But then we also wanted to know, well, how are they talking about diabetes? So in some cases, when they were asked about symptoms of depression, they were actually talking about more somatic experiences that could have been really part of diabetes or side effects of medication. So this one person said, with the diabetes, I tend to go to the bathroom. It's like 3 hours and then I'm up and then I'm back to sleep, another 2 or 3 hours. So, that could be coded on this structured interview as being a symptom of depression, but when you actually look at what he's saying, it really has to do with his diabetes. And then in other cases, they were talking about things that really um, fit closely with the way we think about and conceptualize diabetes distress. So this is an example of what we call regimen distress. Someone saying, I gained so much weight. I've never been this big in my life. And part of the weight is it's due to the medication I take, and that really depresses me. They also talked about the emotional impact. So not being able to control diabetes and saying, my doctor and I have tried everything and it doesn't seem to be working. And then we heard some things like this, where there was this kind of interrelationship between diabetes and glucose levels. So this person said, sometimes my diabetes makes me moody, like I can get agitated from my sugar being high. So what we learned from this is that qualitative methods can help us understand symptom context. So, this was really, when we think about like collecting patient-reported outcomes in clinics, it's maybe thinking about that as just a starting point, that there's this whole context that might be important to understand, because that could, first of all, depathologize and normalize some of the emotional distress that can come with living with a chronic condition like diabetes, but also it can inform how we think about how we might intervene and provide treatment. And so again, I kind of wanted to start with this one too, because it was non-traditional in a bunch of ways. We didn't, create the study from scratch. We had this existing material, but in spite of this and how constrained it was, I think it was striking how clear it was that for some people, their distress was really driven by diabetes. So for me, this brought home, some of the value that qualitative methods can add and can be as a complement to quantitative methods, and really like also the value of just listening to people and hearing how they talk about things. Okay. So from here, I'm going to be mainly talking about things involving diabetes technology, because that's most of what I've been doing. So this next project was done in the lab of my mentor, Dr. Corey Hood, when I moved to Stanford for my postdoc. And I think that it highlights the importance of making space for people's voices and experiences who will be adopting health technologies into their daily lives. And so some of you, or maybe all of you, are already familiar with this, but how diabetes technology has really advanced so far. We have CGM, we have insulin pumps, we have automated insulin delivery systems that now can, where the pump can get the data from the CGM, and there's an algorithm, and it can automate some of insulin delivery. So the idea is that really, these devices and these systems, especially as they advance, can help with improving management and diabetes outcomes, and help with the burden and help with quality of life. But for them to work, people need to be able to accept them and be willing to wear them and to deal with the hassles and burdens involved to get the benefits. So that's why understanding the user experience is very important. And so just to define what user experience means, um, essentially with any technology, you have the user, and then that person is interacting with their device. Or it doesn't even have to be a device. It could be like their interaction with the healthcare system. But what is that interaction and their experience? So that encompasses the subjective experience, their emotions and reactions, to just anything that comes up when they're interacting with the device. And there's different time points, like I kind of put this on a cycle of different questions that we might want to ask at different phases in where things are at with diabetes technology. So with existing technologies, or maybe you could think about with existing healthcare, healthcare system experiences, you might ask about, what are the benefits? What are the barriers? Kind of like the good and bad about it. But with technologies, you might want to ask, what motivated someone to choose what they chose? How do they integrate things into their life? Um, did they ever quit a device? And why? If you're thinking about designing something new, you might want to understand, well, what are the good things and the not so good things about the status quo, what they're currently doing, and what do they wish could be done if things were improved. And then you also might want to ask about or try to get a sense of what kind of burdens or hassles someone might be okay with tolerating or managing or working through in order to get certain benefits or as a trade-off. Um, and then if you're doing kind of a clinical trial and you're testing out a system and you might want to get feedback after it, you want to understand the user experience. You want to understand how it compared to the status quo, um, you know, and if someone would make any changes. So this, just for one example of this, we added in a qualitative component for a clinical trial of an automated insulin delivery system. And so the qualitative goal was to understand the user experience with the system that was being tested in the trial. And that was obviously to complement the main quantitative goal of saying, did the system, how was it in terms of safety? How was it in terms of, glycemic management? So for this, we did focus groups. There were focus groups with 32 participants. It was a mix of, there were some adults who participated as well as adolescents, because that was who was in the trial. And there was a semi-structured interview guide. So here are just some of the questions that got at what were your expectations before you tried out the system? What was it like to wear it? So getting at like the physical kind of wearability. What was hard about it and what did you like about it? And um, the groups were audio recorded and transcribed. And then for this, we used content analysis. We first, just a bit about this process, so there were, we had a small team of coders. It was two main coders, and then a third person who could jump in and kind of be there to either resolve discrepancies or talk through things that we weren't sure about. But part of that is to ensure that everything got double coded, but that we also had kind of checks and balances with a third person there. And what we started with was an open coding phrase. So some of you might be familiar with that term, but essentially we went in and we did not have a code book. We just read a transcript or maybe we read a couple. I like to start with reading, 2 or 3 transcripts and kind of do a brain dump of what are all the different things that I highlighted that could be in a potential code book. So in this project, the other coder and we both made our lists, and then we brought those together and kind of merged them and cleaned it up. And that was just our initial set of codes that tried to get at, the kinds of things that were coming up. So this was more of a bottom-up approach. And then once we had that code book, we used that to apply it to the remaining transcripts. But then with each new transcript, we would meet weekly and we'd maybe code a few at a time and then come back and we would iteratively refine the code book. And the idea of doing this is you can keep refining it until the end, but ideally at some point you stop refining it because you stop seeing new codes come up, which means that you've probably done, maybe you've done enough data collection. But once we had our finalized code book, we then took that and we checked it against, like we brought it back to the original transcripts. So everything got coded by the final code book in the end. So, and we ended up getting, this data was so complex, we were able to get 2 different papers out of it because there was just so much that came up in this. So just another plug for really, like, if you go through this process and the data is rich, you can really learn a lot. So in one of our take homes was about expectations. And what we found was that people who came in with really high expectations because they heard about this study, it was called oh, you're going to try out this closed loop system. But one participant said, when I started telling other people about it, I initially said it's an artificial pancreas study. But then towards the end, it was kind of like, well, it's more of a pump upgrade. So it felt a little more incremental than, you know, a total paradigm shift for this person. And then we had an adolescent who said, if you call something a closed loop system, you kind of assume it would give you insulin for everything, it would just do it. So in both of these quotes kind of show that like the words really matter and set up expectations. So whether it's artificial pancreas or closed loop, they were coming in with expectations and kind of let down. Um, And then we also heard more like people who came in with kind of lower or moderate expectations who ended up being pleasantly surprised. Um, so that was kind of one thing that we took away from this data. And then another major take home was about trust because, and this study now, let's see, this paper's from 2017. So now there's a bunch of, FDA approved systems, but at the time they were just in trials. And so people were trying them out for the first time. Um, or just, trying out earlier versions. Um, and there's this whole continuum of trust where, you're this feeling like you're giving some of your control over your diabetes management over to the system. And so on one end of the system, there were people who went in and they did not trust this at all. And this is what, this could sound like. So one person said, I over bolused for all my meals. I felt like I was going high after I ate. Um, and so, they were kind of really frustrated by how the algorithm was working and they wanted to kind of do things to override it. And then on the other end, we heard things, someone really gave their trust over to the system. They'd say things like, oh, you don't have to be as concerned about stuff. You don't have to trust your instincts and, this less worry. So this was, interesting to learn and also raised different questions and implications for us. Like, the people who don't trust as much, if something were to happen with the system, they'd probably be fully ready to jump in and kind of go back to managing how they were doing without it. But the people with really high trust who really gave their management over to the system might, there's concern about de-skilling and would they be ready to troubleshoot issues that came up. So this study, I think, demonstrates just what you can learn about the user experience beyond what this was a clinical trial where really the main outcomes were about glucose levels, time in range, A1C, safety, not increasing hypoglycemia. And so if we had just had the quantitative data, we would know how well the algorithm worked to regulate glucose levels, but we would have really missed these opportunities to learn things that could be valuable for future users of the technology. And we also could understand that there's a range of experiences that people have when, they're thinking about integrating something new into their daily lives. Okay. Maybe I'll pause here and just see if there are any questions or thoughts at this point. Yeah.
I have a question. I think you talked about this anxiety that you talked about was the bias of the people that you're actually studying. And I don't know if you have any comments about that in general or regarding the study you just showed.
For the closed loop trial or for the first one?
Either of them. It seems to me that is such an important thing. Or are you getting a representative sample? Uh, is this data generalizable? Things like that.
Yeah, I think so. Those are really good questions. And I think, we might think about it in a little bit of a different way with qualitative than quantitative studies, because obviously, like the sample sizes are going to be really different, and you can learn a lot from a small group. But you're right that you know, is generalizability, is that really the goal? And maybe it is for some studies, and maybe it is not for others. I think, and I mean, I think we could probably say this about a lot of research, that research participant, you know, someone who's willing to participate in a study, and giving the time to do that may be different from someone who is not participating. So I don't really have like a, you know, I think these are really good questions to be asking. And I think that with the qualitative approach, really the intention is more to be generating ideas and hypotheses for future research as well, and future efforts. So um, I don't know, when I think about generalizability, it's like, can we apply this finding and assume that it works across, you know, a wide population so that we can go forward with a recommendation? But this might be like, this isn't the final step necessarily, but lets us know what we might need to learn, or what we might do as our next step to get more generalizable. Yeah, that's a great question. I think that it's tricky because, um, you know, you're always thinking about like, am I talking to the right people? Yeah. Any other thoughts or questions at this point? I don't know. No. All right. Um, I will press on. I'm going to talk about two more projects. Ooh, there we go. Um, so yeah. So this one, again, the focus is on diabetes technology, but more about existing technologies. And so this comes from the work that I've been doing as part of my K23, where I developed and refined and then have been testing out an intervention with the goal of promoting continuous glucose monitoring uptake in adults with type 1. So as part of this study, we did a pilot, then getting feedback to refine the pilot, and then going on to an RCT. So the part that I'm going to talk about with this is that some ways that we use qualitative methods that I think were for something other than research. It was actually for intervention, like for making the intervention. But I think it highlights kind of a different value the qualitative methods can bring. So just a bit about the rationale. So, and basically the T1D exchange had reported that about a quarter or less of adults with type 1 diabetes were meeting the treatment target of having an A1C under 7. And we know that, one of the things that can help with getting closer to these targets has been using CGM. We also, this is more recent data from the T1D exchange, but showed A1C by device use. And so we know CGM comes with benefits. This was data from over 11,000 people with diabetes. And you could see that, first of all, nearly half were using CGM. So the rates of uptake have increased in the past few years, but there's still a lot of people who, have yet to adopt it. And from this data, we know that people using CGM had lower A1C compared to people who were not. They were also less likely to be hospitalized for DKA and had fewer episodes of severe hypoglycemia. And then, but we know that it's not so simple as just giving someone a device and kind of like set it and forget it. We had done, so, and this was again with my mentor, Corey Hood, at Stanford, but we had done a large survey, so this is starting with quantitative, a survey of 1,500 adults with type 1 diabetes that asked about barriers to device use. And the top barrier was that many people felt like they didn't want devices on their bodies all the time. And some people worried about just what they would do, that it would just be more time consuming, more burdensome, that they'd have all this data they wouldn't know what to do with. They wouldn't want to spend more time managing their diabetes. And that's kind of what they felt that, that devices would bring. Some people who, this tended to be more of the younger adults in the sample, but they didn't want to see people to see devices on their body and to get unwanted questions. So kind of that unwanted attention that devices could bring. And then some people were worried about whether they could trust the device, and worry, what if it is not accurate? Um, Very valid concerns. So this feedback we took this, large quantitative data set, and used that to provide kind of the framework and direction for making this intervention that could target each of these 4 areas. So the intervention is on board, so it stands for Overcoming Barriers to Adopting Diabetes Devices. And again, we wanted to, target those top modifiable barriers by, excuse me. And the structure of the intervention is, it was individual sessions with people who would be started on CGM and then have a little bit more support during their early days of adopting the technology. And we wanted each session to be mapped onto one of those barrier areas that I mentioned. But one of the things that we wanted to do as part of building this intervention was we wanted to incorporate real life stories. So we wanted people participating to get to hear stories from people who had actually adopted CGM and understand how this worked in their life, how they navigated some of these hassles and barriers. Because we were trying to incorporate social learning into this, even though it was not a group, peer support intervention. So this is where the qualitative methods came in. We ended up doing interviews with people with type 1 diabetes who had adopted this technology. And then we essentially, the process of editing and creating these videos that we compiled was very similar to the process of analyzing qualitative transcripts, because we had transcripts of all the interviews and we were able to pick out main, themes and things that were relevant to each of the topic areas. And kind of, organize them to flow together. So we ended up making 4 separate videos, one about wearing devices, one about living with data, one about devices in social situations, and one about building trust with your CGM. And I brought just a little clip to share. This is from, I hope this works, but oh, I may need to share audio. Huh. Let me, I'm gonna stop sharing and then I'll reshare just so you can hear it. Okay. Oops. Oh yeah. Share sound. All right, here we go. Okay. Hopefully you'll be able to hear this.
Getting data every 5 minutes from Dexcom is a lot of information for sure. And I'm a doer. Like, I always want to act on information. So, like, relaxing that part of me was a bit of a challenge in the beginning. I think I'm better about it now. But yeah, trusting that just because there's an up arrow doesn't mean I'll go to infinity, and just because there's a down arrow doesn't mean I'm headed towards 0.
You have more data, so it never really gets away from you. And a friend of mine on Facebook, coined the term hyperglycemia. This idea that I'm always looking at my Dexcom to know, am I going up, am I going down, and there's a part of the technology that you have to sort of distance a bit and live life, and sort of accept that this disease can be controlled to a large degree, but part of it is random, and you have to sort of be willing to work through some of the randomness and live life in between. And with so much data coming in, like sometimes making those decisions can be even more complex. But it's better to have the data than not. So, it's a learning process over time. Where it can get frustrating.
Okay, that just gives you like a little taste. So in each session, we had a video that was kind of like this, that was about, under 10 minutes long, but different experiences from people who had navigated some of the challenges with using diabetes devices and CGM. And by sharing their experiences, each person, they're modeling how they've problem solved their own barriers. And we were able to show a variety of different stories.
Getting data every 5 minutes from
don't play again.
Dexcom is
okay. So, and then I just wanted to give an extra plug because just in terms of how these methods, we used qualitative methods truly because these were in-depth interviews. They were more focused because we had that kind of a priori, these were the topics we wanted to cover. But then the process of selecting quotes, analyzing the transcripts was very, very similar. And just in terms of, other ways that these same interviews were used for another purpose as well, which was to create a website that maybe some of you have come across, but called Diabetes Wise. So, and it's worth checking out if you are in a position where you're, prescribing CGM or diabetes devices, recommending them, working with patients. It's a great resource. But and so the two people that you saw in the video, I think they're also featured on this website. But basically, it's a site that Dr. Hood and his team at Stanford put together that it shows all of these stories, real life stories, and some of them have videos and some of them are just kind of quotes. But for people who are interested in learning more about diabetes devices, to go and read real people's stories and get a sense of things in kind of a non-biased way, because it's not supported by any particular device brand or company. So just some ways that these kinds of methods can be used to make different interventions, including one like this. So that was to develop the intervention. And then in terms of refining it, we did more of a traditional approach for the onboard study, which was that we did a pilot. And then, we obviously wanted to know about quantitative things like time in range, A1C, diabetes distress, with a self-report measure. But we also did interviews and focus groups with the participants afterwards, and which we analyzed with content analysis to get at feedback that could be used to refine the intervention. So this was just a feasibility study. We talked to, so it was 22 people who were in the pilot. They were all adults who had, for the pilot, they had all started on CGM in the past year. And we were able to do a couple different things with these interviews. So we were able to both get feedback on the intervention, and we were also able to hear their stories of what it was like for them when they started on CGM, which they did on their own. It was not related to the pilot study. And what we learned, we learned some really interesting things from this. So first, we learned that, people who had started at CGM on their own experienced a lot of these common pitfalls and challenges, like bleeding with insertion, a sensor falling off and, just out of the blue, losing signal, compression lows, which is when if you happen to be sleeping on your CGM, it puts pressure on it, and then you could be woken up in the night with an alarm saying that you have an urgent low, but it's not true. It's just because of because it's a compression low. But all of these things, when someone experienced them for the first time, were quite distressing. And this, again, like they were on their own kind of figuring it out. And so it obviously brings up the question, if they have those kinds of experiences very early on and they don't know that they're, a possibility, it could lead someone to question, are they going to continue to use this device? And, what are they going to work through this, or are they going to just say, this is not worth the stress? So just to share a few quotes that show kind of the emotional salience of these experiences. One person said, the first time that they had bleeding when they inserted their CGM, they were terrified that it wasn't going to give accurate readings. A quote from someone whose sensor fell off. They were given this overlay tape and said, this should be fine, but then it would start to peel after, a few days in. And this participant said, I would be afraid. It's like, what do I do? Because you think about, if it comes off, is that going to be expensive? Is that going to be, it's supposed to last the number of days it's supposed to last. And then we also heard about reactions to trend arrows. So people, really kind of having a true, real emotional reaction and being frightened when they saw double arrows up or double arrows down. And then, would respond accordingly. So we learned a lot since we were doing a CGM onboarding intervention. That qualitative data was really useful for going back and looking at our materials, adding in some things, refining some things, and also just understanding what kind of the status quo was for the folks who were in the pilot, who were kind of just prescribed it. Most of them really started on their own. They were self-taught. So, we heard a lot of, people watching YouTube videos, looking on Reddit, kind of going online and figuring things out themselves. And then we also heard that there was this need for, or just a desire for more attention given to the emotional side of having all of this data. So this participant said they wanted like a handbook of how do you deal with it, and also the mental health part, because the data can be super overwhelming. And another participant said kind of something along those lines as well, that people don't really get training for how to manage and kind of like live with this constant stream of data. And so they wanted training and just kind of more support around being healthy with the data, and using it skillfully and wisely, because this person said it could be a whole anxiety disorder category in and of itself to be just constantly looking at the data. And then the other thing that we heard from them was that they really wanted real talk from, they wanted to be able to just like talk to someone who knew, basically peer support, someone who knew what they were going through, but also in real time. So when they were having an issue, having someone to reach out to. So this person said, it's one thing to get information from a Google search. It's another to talk face to face with someone and say, here are the issues I'm facing, and then have someone say, I've had exactly the same issue. So getting that advice in real time, which we weren't exactly, I wish we could have incorporated that into the intervention we were making, but just really helpful for thinking about next steps and kind of future possibilities for what could be most supportive when someone is starting on a new diabetes technology. So I think, hopefully these kind of show the storytelling aspect, I think demonstrated for me how qualitative analysis can be applied for other purposes than just kind of the traditional way we think about it, where we're interviewing participants and, taking that information and maybe we're going to write a paper. But this was a way to, create an intervention that would go and support other participants. And I will say, a lot of the participants in the study who got to watch the videos really were touched by them and felt like, and especially people who hadn't necessarily connected with someone else with diabetes in their life before. It wasn't quite, it obviously was not real-time peer support, but there is something very validating because for some people it was like the first time they had heard anyone with their same experience talking about it. And again, for this project, it's interesting, just kind of we started with quantitative methods. We had this large survey that helped us decide priorities of the intervention and create the content. Qualitative methods helped get feedback, but that these methods like really go together and complement each other in a lot of different ways. Okay, I realize we're over an hour in, so I think maybe we'll take a break for like 5 minutes and come back at around 10 after, does that sound good? Yeah. Okay. I will see you all in a bit. Okay. All right. I'll go ahead and get started. I just have one last project I wanted to share about, and then we can do a little more interactive stuff. So let's see. So this, and the reason I wanted to talk about this one is it involves rapid qualitative methods, which are becoming a lot more, I think there's a lot more interest in them now, for reasons that, well, it's rapid. So it's really good for, I think it's used a lot in more implementation, health services research. Um, so this study was one that also focused on existing technology, CGM, but this time, so this was done with the pediatric diabetes team at Stanford, which is led by Dr. David Maas, and the study called the 4T study. So he had grant support and CGM supplies to be able to provide all youth who were newly diagnosed with type 1 diabetes with to get them started with CGM within a month after diagnosis. So because this was a totally new practice to be able to introduce CGM in that brief time frame following diagnosis, they wanted to collect some qualitative data to find out how, was this being accepted? What was the experience like, since this was a new clinical protocol? So we used rapid qualitative analysis because part of the goal was to help with improving care. So we really had two overarching goals. One, there was a research goal and this clinical translational goal. So the bigger picture kind of research questions were, would this be, what were families' experiences of being started on CGM? Would it be acceptable to them? Was it overwhelming? What were the benefits and the burdens? I think perhaps it was previously assumed that adding on a new device during this initial period following new diagnosis would be too much because there's already such a steep learning curve, so much to adjust to. And so adding on a new device would just only, add to that. But we wanted to know what the actual experience was going to be. And then we also were interested in kind of the clinical delivery and being able to provide more direct feedback to the clinical team, which was made up of endocrinologists, diabetes educators, nurse practitioners. And so we kind of got together and we asked them, what are some of the things that you want to know about? So it was kind of a multidisciplinary group who contributed to shaping the interview guide. And then they wanted to know about, specific aspects of care delivery, about timing, about the teaching, was it enough teaching, the pacing of visits related to everything else that they had going on. And then this project also involved something novel, which was novel at the time, which was that the families were, their child CGM data was being shared with the clinic. And so there was a team kind of in the background who was following the data and providing feedback between clinic visits on, how they were doing and maybe making, adjustments to medication and things like that. So the team wanted feedback on that as well. So for this one, we did focus groups and interviews. So this was on Zoom with 16 parents of youth who had been newly diagnosed. We had a semi-structured interview guide, recorded, transcribed them, and then we had these two goals. We wanted to analyze the data, but we also really wanted to give feedback to the team in a timely manner. So this was where the rapid methods were a more efficient way of delivering that feedback while still ending up doing our full coding of the data. So I know at the beginning I mentioned, how much I love being adrift in the sea of data, doing the bottom-up process, letting the data really drive the organization of codes and themes. And that is really appropriate for a lot of projects. And I also feel personally that even if you have a more, more strong kind of like top-down idea of the things that you want to learn, I always think you want to leave room for things in the data to surprise you, um, which is where the kind of bottom-up approach comes in, just staying open. But sometimes we really we do know certain things. They could be broad categories, and we want to learn from, you know, basically these rapid methods can help when we already have some of the initial structure of what we want to learn. And sometimes that can be a better fit. And so this is like the metaphor that I came up with to describe the top-down approach we needed for the rapid phase of the project, which was inspired by a day deep in the pandemic when my kids thought that it would be a fun idea to take every single toy we own and spread them all out over the floor. And so the prospect of starting out like totally adrift in all these toys and then organizing them all over again can be overwhelming. But luckily, we had this little like bin organizer thing. And so there's a blue bin for instruments, a red one for magnetiles, and so on. And luckily, I had a coding team with expertise who was going to help get everything back where it belonged. So there's my coding team right there. So with a more top-down approach, you start adrift in the sea of data, but then you have this predetermined set of codes or a framework and the sense of how you want your data to be categorized. And so you're kind of just, you know, putting things into the bins, but you're deciding upfront what the bins are. So for the rapid phase of this, we had one strength is that we had a multidisciplinary coding team. So it was me, the psychologist, we had a pediatric endocrinologist, we had an exercise physiologist who is a diabetes researcher who also lives with type 1 diabetes. And so the three of us were coding together and bringing, you know, kind of our different perspectives to the data. And then what we did was we created a table, or they call it a matrix. Basically this is like the predetermined buckets of information we wanted to collect. And so after doing some initial reading through transcripts and creating the code book, we used the code book to make this table. So you can see this is a blank one. We wanted this to be a rigorous process still, using the rapid methods. So we still double coded all the transcripts, meaning two of us independently read each transcript and then filled out this table independently. So we would kind of summarize what was some of the feedback that we heard in these main like key categories that we really, we boiled it down because our interview guide was longer than this, but we just kind of picked out feedback of the timing, initial learning curve, experience with that first CGM education visit, telehealth delivery, we wanted feedback on that, and then the remote monitoring, the messages that they'd get from the team in between visits on their data. So every coder would fill this table out and put example quotes for what they found. So this way, we could always go back and find where this data came from if we had questions, like we'd know, and this would be, one of these for every transcript, that then we came and we would meet together, discuss questions that came up, we'd resolve discrepancies. And so this is an example of what a filled in table looks like, just to show that it summarizes the main findings. So there was a parent who shared that they actually wanted their child to have a few weeks after diagnosis to get used to doing the finger pricks before starting on CGM. So we had different feedback, one person, so saying 3 to 4 weeks after diagnosis, or waiting a month will help the child's emotional adjustment. But this was different across different people said different things. Some people said they wouldn't want to wait at all. We also got really helpful feedback that people wanted to know education about when their transmitter would expire, so they would be prepared for that and getting the new one. we got some really helpful feedback about just the timing of the first and second visits. So, and this just was helpful to kind of see, it's like a snapshot that boils down from a whole big transcript. These were like the kind of key findings. And then, so we had a table like this for every focus group. We synthesized them across coders and then across all of them to make kind of a big master table. And then the final product for the rapid phase was that we had a very condensed, we basically made a one-pager, a summary that I'm going to show you, but obviously way too small for you to probably read all of it. But this was the one page of, this is all the feedback that we were able to give to the clinical team that summarizes all the key points. And then we did kind of a more in-depth presentation that got at all the things that they were, the key areas they wanted feedback on. And then beyond providing the feedback, we were able to publish our findings on overall the early introduction of CGM, as well as we had done a follow-up study to this because during COVID, all of these CGM education visits became virtual. And so we wanted to understand how was that for was that accepted? Was that okay? And, overall, people, we were able to share, and this was like a really positive aspect of this project, to be able to share with the clinic team some of the positives. People kind of were raving about providers and just had like really, really positive things to say. And it's always kind of gratifying to be able to give that feedback. And then we were also able to pass along some very, very minor and kind of constructive, tangible feedback that are things that were easily addressable. So, one thing that came up was about the timing of the visit around the first sensor change, because what would happen is they'd have their first sensor put on in clinic, and then their next sensor change they'd have to do on their own because it was 2 weeks before their next clinic visit. And they found that very anxiety provoking to have to do that first sensor change. So they were able to like tweak some things and give support for that first change to help with making it a little bit less distressing and more useful, more kind of timely support for families. So rapid methods can be applied to get feedback from patients and their families in a way that can have a direct impact in the way that healthcare is delivered. And in the case of this project, in a way that validated larger efforts of the clinic team who are working so hard to implement this new treatment protocol. And I'll say that parallel to this process, we did still do a full coding of the transcripts. So we started with this rapid approach, but then we ended up doing, more of a full analysis that we were able to kind of look at larger questions about the experience of early CGM initiation. I know I have not mentioned qualitative software at all, but we use in vivo. So for this one, we entered the codes into in vivo, and that process, led to writing the papers. Okay. So I hope that I've been able to demonstrate some of the different ways that qualitative methods can be used in diabetes research, but this is definitely not an exhaustive list, but I wanted to show how they can be different ways that they can be added on to studies to improve healthcare and understand changes in care delivery, how those are experienced, to develop and tailor interventions, to understand the experiences of living with diabetes. And I think all of the projects I talked about today were just a qualitative component, which is one part of it. And there were a lot of other, quantitative aspects to the study, but I think they enhanced our understanding and added depth by incorporating the voices of people with diabetes. Let's see. Okay, I have like 2 slides that I put together with just some like words of wisdom that I'm going to share. So one, and again, like this is just kind of intro, how you can use qualitative methods, but not the like nuts and bolts, which I think it's really best learned by doing it. But if you are wherever you're at in thinking about using qualitative methods, maybe these will help along the way or in the future. So first of all, about the interview guide. One thing is that just the interview guide is what drives the results. So it's helpful to, be really thoughtful. I mean, this is kind of stating the obvious, like you want to care about the questions you're asking, but the things about phrasing, making sure you're asking open questions. Sometimes the order of questions can really matter. How you are starting and getting into the interview and how you are moving through it. How much you're trying to pack in to an interview guide also matters. Um, I've I've done a lot of qualitative interviewing at this point, and I know the kind of experience of, when you're given a really a lot of questions to ask, not a lot of time to get through them. That can be, uh, there's pros and cons because you may get some of the information that you want on all these things, but you may lose some of the depth from being able to kind of probe deeper and ask follow-up questions. Um, the process can be iterative, and that iterative process can happen during the interviewing and the coding. Again, I think you learn by doing. So it is acceptable in qualitative methods to do a few interviews and then ask, how is this interview guide working for us? Are there certain questions that are kind of landing really well, are getting someone to open up and, getting the information that we need, and others that we're just kind of getting one-word answers to? Um, or maybe, something comes up in an early interview that makes you want to add a question. So those are changes that you can make, especially, early on. It's okay for it to evolve over time. And then obviously during the coding, I think it's really important for that to be an iterative process, because you're going to choose one transcript to code first, and maybe that will inform your code book. But the 10th transcript might have something really valuable that you hadn't really picked up on, but someone says it in a particular way that makes you realize, oh, this really was kind of there in pieces in these other transcripts. Um, and then I think it's really important in terms of the interviewer to have some training before going in and doing the interviewing. Um, I think that, especially around knowing kind of when to ask follow-up questions, how to probe, how to ask for clarification. Those are things that, they come with experience, but can be helpful um, to know kind of, and to feel comfortable, to have someone feel comfortable to maybe not stick 100% to the script if it means asking for a little bit more information and encouraging someone to share kind of their full thought. And then for coding and beyond, one thing I like to say is I think about approaching each new study with beginner's mind. So even though, I might be an expert, like, I've done a lot of qualitative studies, but each new study, you're going to learn something completely different, and staying open to that. And I think that's really what keeps me excited, and why I really love this work is because you get to learn something new and you get to be surprised. And if you go in kind of assuming that you are going to know what the answers are going to be, you're going to lose some of I think the spirit and the reason that we want to do these interviews. Because I mean, I didn't put this anywhere, but I always say in interview guides, like telling the person, they're the expert in their own experience. We're here to learn from them. Another thing is to plan and budget for how time intensive the coding takes. I mean, some people know this and feel like it's a deterrent to doing qualitative research. If you don't know, if you haven't done it yet, it is very time. It's it's an intensive process. It's ideal to meet weekly. It obviously depends on your N of your sample, but to really give it the time and attention and thoughtfulness that the coding kind kind of benefits from, you want to put that time in. And I also, I tell people that the more time and thought that you put into the coding phase, your paper will basically be written for you. Like you will have written your results section by the time you're done coding. Because that work, that kind of intellectual work of synthesizing and putting everything together has to happen at some point. And for me, I think my preference is that it happens during the coding, because then you already know what you're going to say in the paper. And I know there's probably, I don't know, depending on, for who's on this call, but people who you might be interested in incorporating qualitative methods and adding on a qualitative component, but not necessarily being the one to do it yourself. If you have not been involved in doing coding yourself, even just for one project, I think it's just helpful. And also, if you are coming from a different kind of area of expertise, like you're going to bring something really useful to the data, like your perspective. And so just to know, just to kind of like be in it and see what the data is, I think is good to get experience with. And then the last thing is kind of an obvious one, but you for publishing, there's journals that publish qualitative papers. And so it's always good to like read examples, look at models, and if you're thinking about writing a paper that's qualitative or mixed methods, just seeing kind of what's been published is good to do. Again, I put together a kind of a one page that has some resources, some links to books, some links to the qualitative checklists that are used to report the, kind of stick to standards of qualitative methods in when you're writing papers, and some videos. There's a couple things on there as well. Okay.